The next topic is rehabilitation of spinal cord injury, excluding bowel and bladder by Dr. K. M Mathews.
Must have heard Kakacheshta Bako Dhyanam, Shwana Nidra Tathaivacha, Alpa Bhogi, Graha Tyagi, Vidyarthinam Panchalakshanam. You want me to explain it? Kakacheshta, you should have curiosity like a crow. Kaw, 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 kaw. Kakacheshta Bako Dhyanam. Your concentration should be like a stork. Bagula. Shwana Nidra, you should sleep like a dog. Tathaivacha, Alpa Bhogi. So don't get too much into materialism. Alpa Bhogi Graha Tyagi. Leave your home and all your friends and family away till you do not achieve your educational qualification to an up to standard. Vidyarthinam Panchalakshanam. So these are the 5 qualities of good student. So you should ask question like a crow.
My time starts only now, okay? Good morning. Come on, guy. Good morning. Good morning. Very good. Who are the residents or registrars? Who are the people who have come for this as a course? Can you raise your hands? Brilliant. Residents. Who are the residents is what I want to know. Thank you. Now, I'll tell you something. My good friend Sanjay Pandey told me, this is a wonderful topic, but they have asked you to exclude bladder and bowel. This is like giving you a lollipop without the sweet on it, only the stick. And I agree with it completely. And then I listened to George. George even chewed the stick, so I'm only having a chewed stick with me. So we're going to start there. This allows me, therefore, to improvise. I'm just going to use my slides as a prop and I'm just going to ask questions. And do you know who will get the first question? Anyone? Yes, the person right at the last. Okay? That very end. That's a table we'll start with. Thank you, we'll start. Oh, those 2 pictures. The previous picture is where I now work. This is where I used to work. But we will go on. I'm just showing this only to let you know that increasingly in India also we are getting a large number of tetraplegics. That was not the case when I started my career about 40 years back. So we are now getting a lot of people with cervical spinal cord injury. How do I know? That is some of the figures that I had in 2021. About 58 people we treated in 1 year cord injuries. You can see the majority of them are actually cervical cord injuries. 70% of all people who come now in the West with cord injuries have incomplete cord injuries. And let me define that for you. If you don't have sacral sensations, you cannot call it incomplete. It's really important to know this. Okay? You need to have sacral sensation to call it incomplete. And so 70%, if you add up all those circles, you will get 70. But you can see that 52% of the people who come to my center in Kochi are also incomplete. So we are increasingly getting a larger number of people with incomplete cord injuries, and there lies our opportunity. I don't want to go back into this. Already a big session has been done on classification. But it's vitally important to know the level of lesion and whether it is incomplete or complete. There we are. Now, again, this has been already dealt with. Why do we need to know all these things? It's really important to classify it as AI as A to D. Because you can actually predict who of those people will be walking. That is done on a very large number of people. So these figures are really valid. If you're under the age of 30 and you come with an incomplete spinal cord injury with pinprick sensation sparing, in the A&E, go and tell them that they will walk out of the place and you will be right. If anybody asks you who said that, just say that Dr. Mathew said it. They might kick you out. But no, you will be right if you say that. The physiology of sympathectomy we should know, because the majority of people who are now coming are coming with cord injuries at the cervical level. Increasingly, sympathetic outflow is cut off, so you will have sympathectomy, high levels of sympathectomy, which will lead to spinal shock. In spinal shock, we'll have low BP, low pulse rate, and warm extremities. This is not to be confused with hypovolemic shock, where you will have low BP, high pulse rate, and cold extremities. Now, George, with apologies to you, I'm going to say, because you've not done it for 15 years, acute cord injuries, they come to the A&E, do not give them fluids and try to resuscitate them. It never works. Catecholamine, high levels of catecholamines are in circulation. They make your bronchial vessels porous. Fluid will come out of your vessels, flood the lungs, and you will be going into the ICU unnecessarily. So, no fluid resuscitation for people in spinal shock. We are not talking about hypovolemic shock. Hypovolemic shock, the treatment is fluid resuscitation. In this one, no fluid resuscitation. You need to give them sympathomimetics. I can go into the details of that, but that's not the time for this. Then preventing complications, like George emphasized, is really important. So he already mentioned all this, so I'm going to run through this. Put in an NG tube always for the first 48 to 72 hours at least. Otherwise, you will have acute gastric dilatation. You have not heard of it. If you have not heard of it, and if you don't do this, you will end up with an acute gastric dilatation. What that does is to splint your diaphragm, not allow you to breathe properly and cause problems with your respiratory system, especially in high cord injuries. So put in an NG tube, it decompresses it, and it allows the other bowel movements to start off. This is a common complication you will find in an acute cord injury, high cord injury. You will have mucus plugs, you will have things, this is called a whiteout. One half of your thoracic cavity will be completely blocked off, so you will get this kind of a picture in an X-ray. 5 minutes later, with good thumping and assisted coughing, that's what you will get. These are real X-rays. I'm not trying to manufacture this. So good respiratory therapy is essential to make sure that you don't get mucus plugs, and if you do, then you will be able to get it out very quickly. All it takes is 5 minutes of thumping. Good percussion, assisted coughing. That's how you do it. And you can you see something here? Oh, I don't know. At the bottom, can you see a silver kind of thing? We have, at the bottom of the thing, you can see a blanket there. That is called a space blanket. It is routinely used in people being recovered from accident sites, especially in cold countries, because poikilothermia is deadly in cold countries, really deadly. And therefore you should be, when I say deadly, people can die because of hypothermia, and therefore you need to cover them with space blankets in order that they don't lose temperature. Why is that so? Because you got sympathectomized, all your vessels, all your cutaneous vessels are wide open, and you just lose heat like as in a radiator. There's no way to control it. The only way to do this is to cover them up properly. But the same is also true when they are overly covered up for a long period of time. They start increasing the temperature within their body. So very often when you see a person who is covered up and with a temperature of 99 edging to 100, make sure that you take off the cover and you will find that the temperature comes down. These are real issues. These are not manufactured or imagined issues. Right, DVT. Over 80 to 90% of people who are untreated, whom we do not treat for or prospectively for DVT, will end up having DVT. The problem with DVT is if you have DVT in higher vessels, like in the large femoral vessels or pelvic vessels, there's a serious risk of that dislodging and getting into your lungs, causing pulmonary embolism, which can be life-threatening. Now, even if they are on full anticoagulation, you could still get pulmonary embolism. I have seen young people dying like that. on full anticoagulation with warfarin dying from pulmonary embolism. So it's not to say that they won't die, there is no risk at all, but we are trying to reduce risk as much as possible. And initially you start off with low molecular weight heparin, and then move on to oral anticoagulants. We used to use warfarin. Warfarin is inconvenient because you have to ask for INR very frequently to regulate the optimal dose of warfarin that we give. The newer ones do not require that. Again, somebody else is going to talk about, I told you, I've got a stick with the thing chewed up halfway. So somebody else is going to talk about that, so I'm not going to dwell on that today. Pressure sores is a pet topic of mine. So easy to get pressure sores. Therefore, make sure that they don't get a pressure sore. In the West, if you had a pressure sore, it is 8 to 12 weeks in hospital and 15,000 pounds expense. In India, in Aster, if you get a grade 4 pressure sore, it's 8 weeks in hospital and 8 lakh rupees. Totally unnecessary. Forget about the expenses. The risk that you send this person into is pretty severe. So, better to prevent it. That is grade 1. It is because it's so easy to block capillaries because it's only got 12 to 17 millimeters of pressure. So easy to block them. In fact, just lying down in bed will actually close up any capillaries in your body. You don't get a pressure sore because you got sensory feedback. They do because they do not move around as they don't feel uncomfortable. Not imagine, these are real things. You can get pressure sores like this. You can see the head of the femur sticking out. It requires a huge amount of work to make it like this. But why go in for it? When you got a septic arthritis, an open femur, we needed to cut it off. Don't do this. Better to prevent it. And the cornerstone of pressure sore prevention is to relieve pressure. If you don't have fancy mattresses, turn them every 2 hours. If you have fancy mattresses, use them. There are mattresses, there are non-mattresses. There are beds that can actually totally prevent pressure sores, which are called clinitron beds or fluidized air beds. You'll never get a pressure sore, but unfortunately you'll be in one position for the time that you're lying down in the bed. That also can cause complications, like you can get pneumonias because you have not turned the person adequately. If you have not used proper lung toileting, you will get pneumonias. Right. Adequate nutrition and hemoglobin. If you have spasticity, George referred to it. If you have spasticity, if you don't look after it, you will end up with a deformity like that. That requires a huge amount of surgical work. Why go for that? Prevent it. And the easiest way to prevent that universally for upper limbs and lower limbs is to make them lie prone. If you can get patients excited about it, this is the best way to do it. Otherwise, you'll end up like this with a massive contracture that will then require all kinds of treatment to get it straightened out and eventually surgery to get them to stand. Spasticity. Remember, spasticity is worse in a person having sensory incomplete cord injuries. So if you have sensory incomplete cord injuries, you will have way more spasticity than sensory complete paralysis. Those are the ways, hierarchy of treatment, but you should be able to do even intrathecal drug delivery systems, which we are able to do now. That's a system we implant now. Let's come to some broad consensus. Now starts the questions. C3 and above. How many of you have treated C3 and above cord injuries? Can you put up your hands? C3 and above. Not many. If they are complete cord injuries, most of them die if they are not brought to the hospital in time because they don't have diaphragm working. In the West, they do come to you, and then you will have to actually look after them. Having said that, in trauma, even when you have C1, C2 dislocations or fractures, the cord injury is usually never complete in trauma. But you can get complete injuries from other causes. You can have an epidural abscess that can cause a complete injury. In C4, you will be fully dependent in all activities of daily living because you have nothing to work your hands with. In C5, minimal ADL possible with adaptations. C5 means what? Which muscle will work in C5? Come on, last one. Which muscle? Which muscle will work in C5? Come on. Somebody? Biceps will work. So if you can use your biceps, gravity will enable you to extend your hand. If you can give a palmar pocket, you can actually train them to feed themselves. So there are some things that you can make them do, but there are many things you cannot make them do. Like pushing a wheelchair is not that easy when you have only C5. Okay? By the time you're C6, even pushing a wheelchair is possible because you've got wrist extensors, and if you have capstans on your wheel rims, then you can use your deltoid to extend your elbow. Have you heard of that? Using anterior deltoid to extend your elbow? No. Well, you can. That's something you need to know. If you have C6 level, if you can have capstans on the rim, you can use anterior deltoid to extend your elbow, and therefore they can push wheelchairs. Not very efficiently, but they can. By the time you come to C7, you can definitely push a wheelchair very easily. By C6, you are able to drive a car. So you need to look after them very well, because they can do many things which many people do not know that they can even drive cars. In the West it is possible. Nowadays in Kerala, they will modify cars for you, so you can do driving even in Kerala. Whether you will have accidents or not, only God knows, anywhere in India. So C7 and below, you can be living independently. So below that, it's very easy to think about. What should you do? Any level below that, up to T10, it's not efficient to walk. You can make them walk, but it's not efficient. They consume 350% more energy than if you were not to have any paralysis. So don't make them all walk. It is not needed. It used to be very essential in this country because you had no way to access any service. There was no accessible architectural areas where you could actually use a wheelchair. Nowadays that's not the case. Many places are accessible if they have a wheelchair, to go in a wheelchair. Therefore, wheelchair propulsion is way more desirable than walking, because if you wear calipers and walk, your energy consumption is 250 to 300% more. You get very tired very soon. Why is wheelchair so good? What consumes energy in walking? Anybody? Come on, don't sit there dead. What consumes energy in walking? My time is running out. What consumes energy? What is the determinant of energy consumption in walking? Huh? Center of gravity. That's very good. So, the amount of displacement of center of gravity while you propel yourself will determine how much energy you are consuming. If you have joints, you will actually reduce the movement of the center of gravity. So actually it goes like that, but it's only about 2 to 2.5 inches displacement either way, to the side and up and down. Okay? That's how you progress, your center of gravity. If you just take center of gravity, that is how you progress. Okay? But the displacement is minimal. But if you lock up all your joints, then you will have to really do that. So you're lifting up your center of gravity and you consume therefore more energy. What is therefore efficient about a wheelchair? Come on guys. Huh? What is the center of gravity in a wheelchair? Come on. Anybody? It's a wheel hub, isn't it? Along the axis. That's very good. That means when you're pushing, there is simply no lifting of the center of gravity, so it's very efficient. That's why instead of running, you'll use a bicycle, because bicycles also, the center of gravity doesn't move up and down. It is parallel to the ground. Therefore, if the paralysis is below 10, try make them walk. Above 10, T10, better to actually give them wheelchairs. And independent living is possible once you are below C7. This is what I said. If you have an epidural abscess sitting like that, it will actually thrombose vessels and you could get a complete injury from that. This is what we just talked about. By the time you reach L3, it becomes reasonably okay to walk. You can walk about a kilometer without getting tired. So encourage them to walk. Bilateral AFOs, do not give them a walker. There is no need for a walker. You can give them crutches or a pair of walking sticks. You can get them to train to walk like that because their quadriceps is working. And anything below L5, S1, they will be able to walk independently. Let's concentrate on the hand a bit. C5, what is going to act? The biceps will work, but there is nothing below the elbow. Is any kind of reconstruction possible for activating the hand in a person like that? The answer is there. I'm asking you a stupid question, isn't it? What about C5 with BR, brachioradialis? Has anyone seen a brachioradialis to ECRB transfer? Extensor carpi radialis transfer. I know, Venu, you don't sit and nod. This is meant for the others. It is possible, okay? Brachioradialis to ECRB is possible. What you will then get is extension of the wrist. If you can extend the wrist, then you can do what is called as Moberg 2, which is tenodesis of the flexor pollicis longus muscle. So, in flexion of the wrist, the first web space will open. If you extend the wrist, it will passively come and hitch against your hand. By adjusting the tension of the tenodesis of the FPL, you will get really strong grip, and this is called a key grip. Okay? But if you really want to function with your hand, you need to be able to move your hand forward easily. For that, you require to use your triceps. But in C5 or C6, you don't have a triceps. So what do you do? What do you do? You showed something. Go on. Not anterior deltoid, but no, actually you can have posterior deltoid transferred to the triceps. Okay? Anterior deltoid can be used to extend, but the problem is you cannot take it above your hand. It will fall off like that. Therefore, in order to allow them to actually reach above and do things, you should be able to do a posterior deltoid to triceps transfer. Easy ones to do, not that difficult. Everybody gets fobbed off by thinking it is very difficult. If you are well trained, you can do it and it will give you very good results. So, in C6, I have said C5 with BR, then C6, ECRL, ECRB. Do you know why that happens? How come there is C6 with ECRL alone and then C6 with ECRL and ECRB working? Any idea why? You take a neurotome and you will have cells there, cells there, cells there. Okay? So, brachioradialis will come from up there, ECRL will come from down there, and ECRB will come down. It's the same segment. Okay? Because of that, you can have a C6 level with varying degrees of muscle activation. Okay? And if ECRB is available, then it's very good because you can take your brachioradialis and use it to motorize your thumb actively, you can take the easy RL and use it to motorize your crude grip with all your FPL, your flexor digitorum profundus tendons. Okay? Now this is important to know. Why am I saying about all these things? Because I told you more and more people will come to you with tetraplegia than previously. Therefore you should know this so that you can even advise plastic surgeons about these or hand surgeons about these. Most hand surgeons have not worked with tetraplegic hands, so you are in a position to do that. Now I have told you about ECRB. If ECRB is present, then brachioradialis for thumb and ECRL for finger flexion. When pronator teres is also present, pronator teres can be used for pinch. Okay? And if C7 and FCR are present, you can use the FCR is flexor carpi radialis. It is a very good extensor because all these things that we talked about, the reconstructions for flexors. Extension is passive by dropping your wrist. Okay? But if you have your FCR also present, you can take your FCR and put it into the extensors or the fingers. So you'll have active extension, active flexion. Very good to do. What you guys need to do is to become familiar with the International Classification of Surgery of the Hand in Tetraplegia. Very easily available. Just type that, you will get it on Google. You need to really read that and get to understand this properly, not just for the exams. Maybe nobody will ask you this for the exams, but it will prepare you for a practice, a high quality practice in PMR. This is what I said. You can actually strengthen the posterior deltoid, specifically in a person who is recumbent, and there's a particular way of doing it, and that is to get them to activate the posterior deltoid. Resist it, ask them to push down. Actually, when they are lying down, you will find that the anterior deltoid is very strong because they have to constantly use it. Posterior deltoids become weak, so you just need to actively work with the posterior deltoid. After all, it's the same nerve supply from the axillary nerve, therefore you can activate it. Unless you activate it, it becomes weak. And for people with ECRB and with brachioradialis, you can transfer the brachioradialis to the ECRB. How do you strengthen the brachioradialis? Obviously, mid-prone, resist. I want to ask one person to come and show me how to test the strength of brachioradialis. Who will come? Quick. I got only 3 more minutes. Somebody. Handsome man there, come. Ah, handsome. How will you check my brachioradialis? Yeah, and flex.
Against resistance.
Okay, resist me. Yeah, that's my brachioradialis. But how do you check the strength? No, because you've got 2 other muscles flexing, brachialis and biceps. How do you isolate this? No. Are you saying that biceps won't act in the mid-prone position? It will act. So how will you do it? If you take this off, I'll show you. You take this off. Remember to do this. Always, if you want to check the strength of brachioradialis for transfer, flex it. I can see that. I need to try and bowstring it. If I am not able to bowstring it, it is fully powerful. So I am really not. He's got a very powerful brachioradialis. In some people, you will actually see the brachioradialis, but when you push, it will just bowstring. That's not good enough. Okay, so this is the way to check for brachioradialis. Oh, what happened? Oh, okay. I've actually shown that there. The next thing to remember is, if you have got a tetraplegic, prepare them for reconstruction of the hand. And so you will make sure that the web space between the first and the second, between the thumb and the index finger is at least 30 degrees apart. And in order to do that, you should remember never to press on the phalanx. If you press on the phalanx, your collateral ligament will stretch and it will ruin it for the person. So you need to be able to hold can you see on the picture there? Oh, this picture down here, the metacarpal, the thumb metacarpal and the metacarpal of the index finger is actually stretched. You need to do that, otherwise when you flex your wrist, you don't get opening of the first web space. So you need to do that. And then ideally you should do that for all the web spaces, but more importantly, I've shown you how to do a boxing glove splint. You want to get your MCPs in 90 degrees, so you need to work that properly. In the night time, do a boxing glove splint, and I have shown you how to do that. I've emphasized this mainly because I had only a lollipop with the stick half chewed. So that's why I've talked about this. So I'll end here. I've got 16 more seconds. Any questions, I'm happy to answer. Oh, by the way, I want a feedback. If it's been a bad talk, please boo. If it's been a good talk, please clap. Thank you. That's your feedback.
Thank you for the lovely talk. So we get a lot of spinal cord injury patients, especially cervical and sometimes lower thoracic also. And they complain a lot about, they feel cold, like they feel, especially cervical spinal cord injury patients, they feel cold and then they ask what to do. And sometimes I don't know how to counsel them about it. So how do you counsel the patients when they're like constantly cold?
Okay. Number one, they can genuinely be cold. Remember that, because they are poikilothermic. All the cervical cord injuries, the higher they are, the worse their poikilothermia is. So they can be cold, and make sure that you cover them up properly so they start feeling warm. More in the, what I have seen is in the chronic stages, they will start saying, oh, my feet are very cold, my hands are warm, my one foot is cold, the other foot is warm. That is because you've got various components of your cord working to open or close the vessels in the cutaneous vessels without any control from your temperature regulatory centers in the brain, because they are not connected anymore. They work independently. So sometimes you are genuinely cold because all the vessels in that limb are actually, the cutaneous vessels are actually closed or very narrow. On the other side, it may be warm. You need to tell them that this is because of the cord injury and the associated sympathetic dysautonomia, but it is not going to harm you in any way. What is really harmful is either becoming overly hot or overly cold because of poikilothermia. That you need to teach them. How not to cover themselves too much, not to expose themselves to the sun, because they can become very warm, very, very warm. People can have 100, 101 temperature by just exposing themselves to sun.
So sir, optimal covering is the, like we have to counsel about them, and is there a pharmacological treatment you give them?
No, there is no need for a pharmacological treatment. 80% of the people who come to my OPD never get any treatment. All they require is reassurance. And when I give treatment, so rarely do I prescribe any medicines. All they require is somebody to let them understand or tell them what they are going through. Once they understand, most people don't have any problems. They are reassured. Okay? So pharmacologically, there is no treatment available for one foot feeling cold, one foot feeling hot. There's simply no treatment available. All you need to do is to explain it to them.
For the upper cervical injury, when they get extremely cold or they get extremely hot.
Yeah. Even in paraplegics, this will happen.
I just want to add on the IV fluids. I am with Mathew sir. It is usual for quadriplegics to have a low BP, so you must not be putting fluid into it. It's only when you have a hypotension, that is you have a low BP and a very high tachycardia, then you can suspect hypotension and start with IV fluids.